And in the thoracic image, there are a number of ways in which you can image the thoracic cavity. First of all is the chest X-ray, followed by the CT scan and the ultrasound, magnetic resonance imaging, and there are some new advances. So now about the background of chest X-ray, most of it's the most common radiological investigation being performed. About 40% of all investigations which are performed, they are the chest X-rays. It's a standard component of a pulmonary examination, and its systematic review is very important in the interpretation. What do you mean by systematic review? That means while reporting the chest X-ray, you must follow a scheme, you must follow a system, not haphazardly. Okay. Right. Now, what next is limitations. Obviously, it's a two-dimensional study. It's done in 2D. It's a 2D image of a three-dimensional structure, human being. So there are limitations. First of all, X-ray findings usually lag behind the other clinical findings. Normal X-ray does not rule out pathology. It usually happens in chest. When you do a chest X-ray, it turns out to be absolutely normal. However, the patient complains to you that, doctor, I have cough and fever. So there can be two possibilities. Either the X-ray has not catch up to the disease well, or the disease is very early. Okay. So dependent on good quality image as well. So X-ray is also the interpretation of X-ray also depends how good the quality of a chest X-ray is. We will discuss the quality. Okay. So there are views. There is a posterior view, which is the most common view done. Then there is anteroposterior view or AP view. Then there is lateral view and a special type of view which is called decubitus view. Okay, we will discuss them one by one. First of all is the PA view, postero-anterior view. It's the standard view which is routinely done in the radiology department. And in this view, the X-rays, they pass from behind the patient. The patient is standing, like here there is a female technologist who is holding this X-ray tube. X-rays are passing from this X-ray and they are forming an image in front of the patient. So in that way they are postero-anterior, right? This is a typical chest X-ray PA view, and in chest X-ray PA view, remember the scapula, the medial border of the scapula does not lie inside, does not overshadow the lung. If it is overshadowing the lung, that means most probably you have an anteroposterior view, AP view. Why? Because in PA view, the patient positions himself in such a way that scapula gets out of the lung field. Okay, it does not overshadow. Okay, what other structures are there? We will discuss one by one. What are the structures which are appearing on chest X-ray? Now the second view is AP view. Anteroposterior means that X-ray tube is in front of the patient and the film is placed behind the patient. What is the advantage of AP view? The advantage is that it can be done, the PA view, it is only done in standing position. But AP view, the advantage is it can be done in sitting position, semi-erect position or supine position. Okay. So this is the advantage, that it can be done in multiple positions, so that those patients who are very sick, very ill, they cannot stand properly, they cannot assume proper position. In those patients, you can do AP view. Even those patients who are bedridden, who are hospitalized, you can do AP view. AP is usually written on the film. Okay, and if not written, you will identify it by seeing that heart will be enlarged, heart will appear enlarged on AP view, and also the scapular border will be inside the lung shadow, inside the thoracic cavity. Okay, so this is a typical AP view. See, heart slightly appears enlarged, okay, and the scapular border are inside. They are overshadowing the lungs. Okay, what is the lateral view? Lateral view is done either from the right side or from the left side, depending upon the site of pathology. And the advantage of lateral view is that it localizes the pathology, especially which is posterior to the heart. Because any pathology which is behind the heart, it will not be visible on chest X-ray PA view. It will only be visible overshadowing the heart. So if you are in doubt, you have to do lateral view so that you come to know whether this pathology is in front of the heart in the anterior part of the inferior mediastinum, or it is behind the heart, retrocardiac space. Okay. How it is done? The side of interest is placed against the film. Like for example, if you want to do right lateral view, there is some pathology on the right side, you will place the film against the right side of the patient, and the X-ray tube will be against the left side of the patient. So X-rays will pass from the left side and make an image on the right side. That means any area which you want to see on the lateral view should be close to the film. Okay. Now, what is decubitus film? Decubitus is actually a PA film on side. How it is done? You ask the patient to lie on bed, like for example, he's lying on a couch. Then you ask him to turn to one side, either right side or left side. When he turns to one side, what will you do? You will do the film in front of the patient, and you will place the X-ray tube on the back side of the patient, on the back. Okay. So he's laying supine, then he's turning to one side, and now X-rays are passing from the back to the front. So in that way, the X-rays will be horizontally oriented. This is called horizontal beam film. The X-ray beam will be, X-rays will be horizontal, okay, not vertical. In AP view, while the patient is lying supine on bed, the X-rays are vertical from above to behind, okay. But in decubitus, the X-rays are horizontal. And what is the advantage of decubitus? It is to localize the small pleural effusions, very small pleural effusions which are not visible. When you place the position of the patient in such a way, it will collect down. Similarly, for small pneumothorax, the small amount of air will rise up. So this is the only advantage of decubitus film. And when you do decubitus film, you will ask the patient to assume the position and hold on there for 10 minutes before you take the X-ray, so that you want the air or the fluid to attain their positions maximally before you take the X-ray. Okay. Now this is a lateral view, standard lateral view, but you see here is anterior and posterior are already written. Okay. If even if not written, you know that this is the sternum bone, and behind the sternum is the heart shadow. And what is in front of it? This is the breast shadow. This is the X-ray of female patient. This is breast shadow. This one. Okay. This is heart, and the space in front of the heart behind the sternum, this is the space of the lung which is called retrosternal space. And there is also a space behind the heart which is called retrocardiac space. And what is this thing? These are the vertebrae. Okay. Now, this is the lung anatomy. You know, the right lung has three lobes. Why? Because it has got two fissures. One is the oblique fissure and one is the horizontal fissure. However, on the left side, there is only one fissure. So there will be only two lobes, upper lobe and lower lobe. So the middle lobe will be absent in the left side. So as I was telling you, on the right side there are three lobes, and on the left side there are two lobes, right? Okay. Okay, 1 minute, just 1 minute. Okay. So this was the lung anatomy. Now introduction.